What we're going to discuss during this section is the treatment of C. difficile infection. And this is a slide that shows the menu of options that we have available to us. And they include metronidazole, or so-called Flagyl, vancomycin, fidaxomicin, or Difficid, bezlotuximab, or Zimplava, surgery, and fecal microbiota transplantation. So with all of the options available to us, how do our doctors and providers choose which treatment might be best for us? And the core and ultrastructure for that treatment comes from what's called the guidelines. And this is the most recent guideline issued by the Infectious Disease Society of America. The IDSA issued guidelines in 2018 in the month of February, and within those guidelines they recommended that medical practitioners triage severity of infection based upon a white cell count greater than 15,000 or a creatinine greater than 1.5 milligrams per deciliter. If an individual with C. difficile meets either of those thresholds, they have severe infection. Other patients that don't meet those thresholds have non-severe infection. Those individuals with non-severe infection are recommended to either receive vancomycin 125 milligrams 4 times daily for 10 days or fidaxomicin 200 milligrams twice daily for 10 days. The only individuals that are recommended to receive metronidazole for initial treatment are those that do not have availability to the vancomycin or the fidaxomicin. For initial severe infection, vancomycin and fidaxomicin are recommended. For initial severe complicated infection, these are patients that have a low blood pressure, have a shutdown or a sleeping of their small bowel such that they do not move digestive matter forward. Those individuals that have a dilation of their colon or so-called megacolon, as well as those patients that have what's called shock, meaning that their blood pressure is very, very low as a result of system-wide infection, are recommended to receive everything that we have basically. Oral vancomycin, intravenous metronidazole, as well as vancomycin through the rectum. For those patients that have an initial recurrence, it is recommended that we switch the antimicrobial. It's recommended now that patients either receive vancomycin 125 milligrams 4 times daily for 10 days, fidaxomicin 200 milligrams twice daily for 10 days, or vancomycin in a prolonged, meaning greater than 6 weeks, tapered and/or pulsed regimen. And in subsequent sections, I will define what those terms mean. For those patients with 2 or more recurrences, it is recommended that they either receive a prolonged vancomycin taper with a pulse at the end, a standard vancomycin course with what's called a chaser of rifaximin, another antimicrobial. So we give vancomycin initially and then this other antimicrobial afterwards, or fidaxomicin, or a fecal microbiota transplantation. And in subsequent sections, I will define some of the terminology and some of the studies that have driven these recommendations by the guidelines so that you, as a patient, can understand why various treatments might be more effective for various circumstances.